Okay, good evening, everyone. I see there's still quite a few of you logging on, which is great. Nice to see everyone's faces. It's been an interesting time not seeing the families of Shepherd Lodge and Shepherd Terrace, so really lovely to see you all. I know that I had a chance to see some of you during one of the family council meetings. I hope you're all doing well, and thank you for joining tonight. For those of you who don't know me, my name is Cathy Fiore. I'm the Director of Client Care Services here at Shepherd Village. Again, I appreciate everyone taking the time to log in tonight for this educational event. This event actually is in response to feedback that we received on the communication survey that was conducted in October of this year. Quite a few of you actually asked for more information about COVID-19, the virus itself. And so we're fortunate tonight to have a guest speaker to provide some information to the families and staff about COVID-19. Thank you to those that submitted questions in advance. Many of those questions we'll be able to answer tonight. Some of them, however, will defer to one of the town halls that Wendy Beckles hosts, because that might be the more appropriate forum to answer some of those questions. We have about 45 minutes together tonight. We'll have a presentation and we'll be able to answer some of those questions. However, if you do have a question, please feel free to type it in the chat box in the link below. We will do our best to get to those questions tonight. And if not, we will find a way to answer some of those questions and get that information back to you. Lastly, we are recording this presentation because we want to be able to share it broadly with the rest of the staff and families that could not join us tonight. So, without further ado, our guest speaker this evening has been providing IPAC support here at Shepherd Village and in particular Shepherd Lodge for the last number of weeks. Zahir Hirji is the Manager of Privacy and Risk Management at Scarborough Health Network. He is also certified in infection prevention and control and has been practicing infection prevention and control for the last 20 years in healthcare. During this pandemic, he has been redeployed to support IPAC in long-term care homes and retirement homes, in particular in the Scarborough area. So I'd like to welcome Zahir Hirji. And Zahir, I just think I need to unmute you probably. So just give me a moment. Okay, Zahir.
Thank you. Can you hear me, Cathy?
I can hear you.
Okay, thank you. And if you wouldn't mind, will you also share some of the slides that we have?
I will do that as well.
Okay. And good evening, everyone. And thank you, Cathy, for those words. As Cathy said, I have been practicing infection prevention and control for over 20 years. In short, we sometimes call that IPAC, so you'll hear me use that short form through the presentation. For those of you that aren't familiar with what IPAC is, as an infection control practitioner at the healthcare facilities that I would have worked at, I was responsible for working with the nurses and the doctors and the healthcare team to manage the isolation of patients with infectious diseases like tuberculosis or chickenpox, and to try and prevent the transmission of those organisms to other patients and to staff. As an infection control practitioner, I was involved in the first outbreak of SARS in a downtown hospital in 2003, and was also in a different downtown hospital during the H1N1 influenza pandemic that was in 2009. For this particular pandemic, I've been, as Cathy said, I've been exclusively working with long-term care and retirement homes in Scarborough. And so I thank you for allowing me to have some time to be able to talk to you a little bit about the current situation of COVID, a little bit about some infection prevention and control measures or some IPAC measures that we have in place at the home or that we're using throughout the long-term care and retirement home sector. And to finish off with some strategies that you might be able to use to prevent your risk of acquiring COVID while living at home. And I believe that we'll also have some time for some questions at the end. So just to start off with, COVID-19 is the disease itself. It's actually caused by something that's called coronavirus. The actual organism itself is coronavirus 2. SARS actually stands for Severe Acute Respiratory Syndrome. It was a short form that came along when the first outbreak of SARS was around, and the COVID, or the coronavirus, is the short form of coronavirus, and number 2 is the second one that we've seen. Coronavirus is actually a very large family of viruses, and they can infect humans and they can also infect animals. The outbreak itself actually started towards the end of 2019, and so that's why we have the coronavirus, or COVID-19. However, it wasn't till March of 2020 that the World Health Organization actually declared a world or global pandemic across the world. Next slide, please. So globally at this point, we're sitting at just over 68 million cases worldwide. In Canada itself, we're sitting, as I looked at the numbers today, 435,000 cases. And in Ontario itself, just over 130,000 cases. We've actually tested over 12 million people within Canada. And currently there are about 37,000 plus active cases with just under 13,000 deaths. Next slide, please. This is actually a map of the GTA for COVID-19. And if you take a look at the shades of blue, they give you an idea of how much COVID is actually going across the GTA. The lighter areas are lighter or smaller amounts are decreased rates of COVID-19, and the darker areas are higher rates of COVID-19. And as you can see for the Scarborough area, we've actually got a few areas that have darker blue areas. I can actually tell you that from at the hospital, we have assessment centers that are associated with all 3 of the hospitals. In October and November and into December, we've been testing anywhere of 1,000 to sometimes 1,500 people a day. Our positivity rate has been anywhere. We were starting to see positivity rates of 10, 12% in October. That started to rise, and we've recently seen rates as high as 20%. That means almost 200 positive people in Scarborough itself alone with COVID-19 a day. Next slide, please. So, actually, I think I switch some things around, Cathy, but that's okay. I'll do them in the order that you've got. I rethought some things later on. So I will talk about how COVID-19 is spread in just a couple of slides. What I've got here are some basic infection prevention and control measures that we use within long-term care in the retirement home sector to try and prevent the spread of COVID-19. What we recognize is that we're not going to be able to prevent it 100% from coming within to the home. And so we need to look at measures that we're going to be able to put into place to prevent the spread within the home. So some of those include screening of our staff, our residents, and really anybody that's coming into the home. That includes the whole list of any of the symptoms that have been identified with COVID-19. I've got a slide about what some of those symptoms are, as well as some of the atypical signs and symptoms that you may see associated with COVID-19. We want to check anybody that's coming into the building, as well as the people that are in the building. So residents are usually checked twice a day. Staff are checked when they come in and when they leave. That allows us to be able to do some case identification. So what we're looking for are residents that are developing symptoms. We, at the moment, because COVID is a global pandemic and that's the main infection that we're looking for, anybody that's developing any of these symptoms, we start droplet contact precautions, or isolation as you might have heard it called, and we do some testing. And then you may also know that we do weekly testing, or we've now moved to weekly testing of our staff, both in the retirement home and in the long-term care home. As a basic measure for infection control, hand hygiene is a basic principle that we say is the foundation of infection prevention and control. And I've got a couple of slides of what we consider the moments of hand hygiene, or generally when we indicate that healthcare workers should be washing their hands. Those would also extend to patients or to residents, depending on the kind of facility you're in, and even to the general public, if you were to extend to the kinds of circumstances or experiences that you would come across. In the home, we want to be able to use appropriate personal protective equipment to make sure that while our staff are working with our residents, that we aren't having any kind of transmission between staff and residents or to other staff or to other residents. So that would allow us to be able to use different kind of personal protective equipment. And I think I have a slide on what that is. Some of my role to be able to support the home has been able to try and identify where we need some training and education. And the hospital has even reached out to a number of the long-term care homes to be able to support some of the training and education for our healthcare workers, according to what COVID is, how to be able to don and doff personal protective equipment, how to look for signs and symptoms, to be able to identify if they themselves are developing COVID or if their residents or patients that they're caring for are developing COVID. Fundamental to infection prevention and control, along with hand hygiene, is environmental cleaning or equipment cleaning and making sure that the things that are going between staff and between residents are being cleaned. What's good to know about COVID is it's a really easy organism to kill. When we look at the different organisms that are out there that we can transmit between people, something like tuberculosis is a lot more difficult to kill than something like COVID. A lot of the organisms that we see in hospital are actually a little more difficult to kill than COVID. In addition to that, we have isolation practices that we would use for residents that were identified that were positive. For staff that are identified with positive, we have self-isolation practices that they're asked to use, and they're monitored by public health before they're allowed to be able to come back to the facility. We also try and identify that if there are positive staff or positive residents, have they had contact with anybody else within the facility, and try and isolate those individuals and monitor them for 14 days to try and identify if any of them come down with signs or symptoms of COVID. Next slide, please. My apologies. So this slide goes into a little bit more detail about the screening and case identification that we use within the home. What we try and do are temperature checks on all our residents and staff twice. We're looking for people that might have an elevated temperature in combination with symptoms like there's actually a slide that's going to be coming up that are typical for our staff, that would be typical signs and symptoms for COVID. But for our residents who can't tell us some of the signs and symptoms that would be typical, we're also looking for some of the atypical signs and symptoms to try and identify if they may be developing COVID, but not be able to tell us what might be happening. Next slide, please. So this slide actually goes into some of the signs and symptoms, both typical and atypical, that we're looking for in our staff as well as in our residents. The common ones that you may have heard of or know about are cough and shortness of breath or difficulty breathing. Then there's fevers or chills. Sometimes people don't necessarily notice that their temperature has risen, but they'll find that they're shaking a little bit because they're actually developing a fever. Sometimes we've noticed muscle or body aches, as well as vomiting and diarrhea. So both respiratory symptoms as well as gastro-related symptoms. And one that you may have heard about in particular for COVID is new loss of smell or taste. These would be general typical signs and symptoms, but the atypical ones that we'd also be looking for in some of our residents would be things like headaches that would be persistent, conjunctivitis or rhinitis, often fever, lethargy, or malaise that's not common for the individual, changes in their blood pressure or heart rate, increased falls, or things that aren't usual for the individual, not eating or drinking as well, or not interacting with the same individuals that they would normally interact with, just noticing different behaviors of some of the residents. What we've noticed is that for COVID, the signs and symptoms can present anywhere from 2 to 14 days after you've been exposed to someone with COVID-19. Next slide, please. So here's some information about how COVID-19 is transmitted. It's transmitted by what we call droplets or droplet and contact transmission. Droplets are, or droplet transmission is when there are droplets that are carrying infectious material that exit the respiratory tract of an individual. And so what I mean by that is while someone is coughing or talking or sneezing, there are droplets that are released from their mouth. These little droplets can contain some of the infectious agents like COVID-19 or SARS coronavirus, and their droplets are often propelled a short distance. And they generally, because of their weight, aren't transferred longer or further than 2 meters or 6 feet. They generally don't stay suspended in the air and will fall around the individual who's released the droplets. And so often what we think about from a contact transmission perspective is if those droplets have fallen around me, say, as I'm coughing or talking, then someone who comes into contact with those droplets in that 2 meter distance around me, and then was potentially to touch their mucous membranes of their eyes or nose or mouth, could then inoculate themselves with COVID-19 by contact transmission. So they would release out of the droplets of my mouth, but not only if you were standing in that 2 meter distance around me, then and didn't have anything on your eyes or nose or mouth, there's a chance that those droplets could land on that mucous membrane and cause transmission that way. Or if you were to touch a contaminated surface in that 2 meter distance around me and then inoculated your eyes, nose, or mouth, you would be able to then transmit SARS coronavirus to yourself. And so what we want to do is be able to use some of the personal protective equipment or the non-medical masks that people have heard about when you're out in public to be able to cover up the mucous membranes of your mouth. That personal protective equipment does different things depending on the individual that's wearing it. For someone who may have COVID-19, a mask allows for us to be able to control some of those droplets from spreading that 2 meter distance and keeps them contained. For our healthcare workers that are working with people that might be positive, or for our staff that are inside the long-term care home, we often want them to wear masks and eye protection so that they're covering all the mucous membranes of their face, so there isn't the opportunity to be able to have transmission through any of those. Next slide, please. So back a little bit to some of the foundations of infection control. One of the things that we're always trying to promote within the home, as well as in the public, whether you're in a healthcare facility or not, is hand hygiene. These would be generally the 4 moments of hand hygiene. So when you're going to have contact with a resident or their environment, before providing any kind of care, or after having exposure to body substances, and definitely after having contact with the resident and the environment, we want healthcare workers to use either something called an alcohol-based hand sanitizer or soap and water to be able to clean their hands. The alcohol-based hand sanitizer are things like Fiore, Microsan. You'll often see these as pump stations that are available inside or in public areas. Now you're often seeing them in many shopping malls or in public spaces, but you'll also see them entering and exiting of the home, both on the retirement side and the lodge side, as well as exiting and entering on floors or going into resident rooms on the lodge side, so that it's easily available for staff to be able to keep their hands clean. Keeping your hands clean will be one of the ways to be able to, or one of the ways to be able to kill or remove COVID-19 off of your hands, so that there isn't the potential to then take it to other places or to inoculate yourself. Next slide, please. So this isn't an infection prevention and control measure that we would have normally used, but the pandemic has offered some opportunity to be able to do some things that we wouldn't have done in the past. And so you'll often see that there's universal mask and eye protection while providing care for our residents in the lodge. The purpose of this is to be able to prevent the transmission of the virus, and it works in both ways. So what we want to do is be able to provide care to residents without the potential of the staff members' mucous membranes becoming inoculated if perhaps the resident coughs or sneezes and has COVID-19. But also if the staff are potentially developing COVID-19, because there is the potential there of them developing that with the rates that are in the community, that personal protective equipment also contains the virus from potentially spreading to other people that they may have worked with, or residents that they're caring for, until we're able to identify that they're actually carrying the virus and ask them to stay home. In addition to that, we've got things like physical distancing, so that we have additional measures in addition to, so as you heard me talk about the transmission of droplet contact, by having the personal protective equipment cover the mucous membranes of the eyes, nose, and the face, in addition to keeping our physical distancing from others, there's the 2 protection measures that we have to be able to prevent the spread of that virus going to the next person. What we want to do with the mask is change it frequently when it becomes damp or wet, or when it becomes soiled for any particular reason. And we want to make sure, or when you're wearing a mask that's out in the public, make sure that you're not touching the front of it, in particular when you've had interaction with another individual, because you want to consider the outside of that mask to be contaminated. Once you've started wearing it and had interaction with others, consider the outside to be contaminated. If by chance you accidentally touch the front of it and aren't able to change your mask yet, or to be able to take your mask off, make sure that you do a hand hygiene so that you've cleaned your hands with the potential contamination. Be very careful when you're taking it off so that you don't contaminate your face. And then remember to do a hand hygiene once you've removed the mask off of your face. Next slide, please. So in addition to some of the physical distancing, what we've done or what we've had to do is modify some of the activities that are going on within the home, prevent the congregating or communal activities, or drop the number of people that are involved in those activities so that we can maintain the physical distancing and don't have that close interaction of people within the home. We've also looked at dining and environment, so the dining experience, to look at, well, how we might be able to ensure that we've still got the physical distancing when we're able to do that. And you'll also hear about sometimes in outbreak measures, we would then stop doing some of that dining experience and having to go to in-room tray service to be able to continue to try and prevent the spread of COVID-19 within the home. Environmental cleaning is a big component of what we're looking at, and making sure that it is done on all of the shifts on a regular basis so that we can keep the environment clean, so that those that are out and about on units that aren't necessarily got any identified COVID-19 are continuing to keep those environments clean from the possible introduction of the virus if it was to get onto those units. The home, we've also looked at, and across the long-term care sector, we've looked at how do we also be able to help healthcare workers to be able to minimize the number of times that they may have to have interactions with different people so that we further prevent the transmission of the organism. What we want to be able to do is look at how can we consolidate some of the care that we're providing so that we can limit the number of times people have to see each other, and we can maintain some of the physical distancing so that some of the care activities are done all at once without having frequent close contact with individuals who have to have direct patient care to be able to provide for their care services. Next slide, please. So what happens if a resident does develop symptoms? What you may heard of is that we, because we're doing the twice daily checks for temperature and for symptoms, if we do identify someone who has any symptoms that are developing, we start what's called Droplet Contact Precautions. And it's directly related to the way that the organism is transmitted. What we ask staff to do is wear gowns, gloves, a medical mask, as well as eye protection for all of the interaction for that individual. And that personal protective equipment does not come outside of the room. It's taken off and thrown away or cleaned as appropriate, depending on the type of personal protective equipment, so that that dirty equipment isn't being taken to anybody else or anywhere else within the home. The resident, if the resident isn't already in a single room, we'll try and look to be able to put them in a single room and separate them as quickly as possible from any possible with any possible roommates. We'd also look to do some screening, so some nasopharyngeal swabs, or NP swabs as we call them, to be able to try and test for COVID-19. We don't just generally test residents randomly to see if anyone's got COVID-19. They're not frequently seeing many of the people outside in the community. And so what we do look for is anyone that's got symptoms. We don't want to have our residents go through some of the NP swabs if they don't have to do them. We do, what we also look to do is if we do have essential caregivers that do need to come and see those residents that have developed symptoms, we do ask that they also use that personal protective equipment. And there is education available in the lodge or with the home so that you have a good understanding of how to be able to use that personal protective equipment to keep yourself safe. Next slide, please. There's some additional outbreak measures that we put into place, or some additional measures that we put into place when we've got an outbreak. And so that would be limiting the number of people that are coming to the floor, or limiting new admissions that are coming to the floor. Often we'll start doing testing, more regular testing of both the staff and the residents on the floor. When we identify, or if we identify positive residents, we will look to use what we call cohorting measures for our positive residents, because those are the residents that we can actually have in the same room. What we're trying as much as possible is to keep any residents who have had an exposure to a staff member or to another resident who's become positive to have a room by themselves, so that we're monitoring them and we're limiting the transmission of the organism going anywhere else. Often that will mean the droplet contact precautions for 14 days for anybody who's had an exposure. I can share that in my experience, we have seen some people end up developing COVID at the 14th day of their exposure. We often will enhance the cleaning on the unit so that we're doing high touch surfaces and making sure that places that are frequently touched by either the staff or the residents is being cleaned on a regular basis, and looking regularly for the development of symptoms and testing new residents or staff that are developing new symptoms. Often what that means is doing testing every 3 or even potentially every 3 days, often every 5 days at the moment. This would also look at monitoring our residents that are positive and making sure that they're still doing well, and if required, doing some transfers to the hospital under droplet contact precautions. All of this in collaboration with our colleagues from public health. Next slide, please. So just some couple of slides to just go over, and what I'll share is some of this information. What I can share with Cathy is some of these last slides are actually information that's available from Public Health Ontario. There's actually a really nice document from Public Health Ontario, some of the things that you can do to keep yourself safe. I also found there today some information around non-medical masks, and so what I'll do is share that link with Cathy, and she can share that amongst the community, so that if you're looking for some resources after the fact, you'll be able to go and find those. So what we want to identify, and there may be those of you in the audience that might be that might have some of these increased risk factors, or your family members that are in the home may, but in particular the individuals that are at increased risk of having some more severe consequences associated with COVID-19, or those that are the elderly, or those that have chronic medical conditions, or happen to be taking medications that are weakening their immune system. Next slide. And so those are the people in particular that you want to sort of have a high eye or a particular eye on, because if they were to get COVID-19, they could sometimes have some of the badder outcomes. Go ahead, Cathy. Thank you. So for you, some of the things that we are unfortunate but we need to do at the moment are limit the number of people that you're physically near. What you really want to do is only associate with people that you know that are within your home, and stay as far as way possible from people that are outside of your home. That's even people that are from your family but not really from your household. What we don't know, and what you are aware of, is the high rates that are in Scarborough. You don't really know where people have been that have contracted COVID-19. I can share that there are a number of people in the community that when you go back and ask them, where do you think that you might have come across someone with COVID-19, they're just not sure. They've been working from home. They don't take public transit. They've only been going to the grocery store. And so it would be some of the limited community exposures that you and I might have that we think we're doing our measures, but seem to be innocuous places that we might be able to pick things up. Use some of the other measures like phone calls or video chats to stay in touch. If you do need to stay, or if you do need to see people, or if you are having to have contact with people, try as much as possible to make sure that you all stay 2 meters apart or 6 feet apart. If it's possible to do the interaction outside, that's better than being inside. If you're able to work from home, that's a lot better than having to travel on public transit and being close to people in the public that you don't know where in fact they've been. But if you do have any signs and symptoms, definitely go to one of the assessment centers to get a test done. Next slide, Cathy. With regards to indoor spaces, as much as possible, avoid crowds and indoor spaces. Those are the places where it's a lot easier for those droplets to be able to then cause more and more environmental contamination. And that's where the contribution to that contract transmission just becomes more and more, or increased and increased. If you think about an individual who's in an indoor space who just keeps coughing and coughing and coughing, as they travel through that indoor space, they just contaminate and contaminate and contaminate. The organism itself can sometimes live in spaces that aren't being cleaned on a regular basis. And so there's the opportunity in some of the public spaces to pick up the organism from the environment and then inoculate yourself. So regular hand hygiene would be something that you want to make sure that you're doing frequently, maybe more often than you're used to. Look to maybe even put some alcohol-based hand sanitizer in your pocket so that you have it available with you. You might, if you're going outside, want to make sure that you're wearing a mask. If by chance you happen to be someone who doesn't know that you've got COVID, it'll at least contain that virus and prevent it from contaminating the spaces. When you're out and about, if you happen to be accidentally close to someone within 2 meters, at least you've got some coverage over 2/3 of the mucous membranes of your face to be able to protect you. Next slide, please. So for our healthcare workers, we do ask them and do sort of mandate for them that they are wearing what we consider medical masks. For many of you, and you will have seen a lot more availability of non-medical masks. There are a variety of them. They really are out there to be able to help the individuals who may potentially be carrying COVID from preventing that transmission to other individuals. There's a lot of discussion around the type of mask, and like I had said, there's a really nice article from Public Health Ontario that provides a little bit of information on the type of medical mask that you might want to consider if you're looking for one in the public, and I'll provide that link to Cathy so that she can share that. Next slide, please. I would be remiss as an infection control practitioner to not harp again one more time on hand hygiene. It is the foundation of infection prevention and control. It is the #1 way that you'll be able to prevent the transmission of infection. In addition to the fact that there are a number of respiratory viruses that are out this flu season, so RSV, influenza, SARS coronavirus itself, all of these things are easily killed with properly killed hands with either soap and water or alcohol-based hand sanitizer. There's a variety of those that are available through common drugstores that you'd be able to purchase. Just make sure on the back of them that they do have alcohol in them and that the concentration of alcohol in them is 60 to 90%. It is the alcohol that provides you that rapid kill of the organisms. Next slide, please. And just some final strategies, other strategies that keep you healthy during the flu season. So please do look to be able to get your influenza vaccine. One of the things that it'll be able to do is try and prevent you from picking up influenza during this flu season, and at least prevent the possibility of trying to figure out, is this flu, is this COVID? There are a number of other respiratory viruses that do go around at this time. And unfortunately, there aren't vaccines for those, but at least with this one, there is the availability of something to be able to prevent you from acquiring that or prevent some of the complications associated with that. Within your home, do think about cleaning some of those frequently touched surfaces that many people would be touching. Those would be the common spaces that you would pick it up by contact. If you do develop symptoms, like I said, go to one of the assessment centers. I believe at the moment it is by appointment, but I can tell you by experience that you should be able to get an appointment, hopefully within the day or the next day. And it does seem to be that the results are coming back within about 24 hours. So. Thank you very much. Cathy, I think I went a little bit over what I was supposed to, but hopefully some of that information was helpful to you. And if there are questions, I'm happy to take those.
Okay, great. Thanks, Zahir. That was great. As discussed when we started, we did have some questions submitted to me via email. So I thought we would go through some of those questions, and then there's a handful of questions in the chat. So why don't we get started on that, Zahir? So I think probably 50% of the questions I received were related to the vaccine. Of course, it's all over the news right now. We're all anxious to hear about the vaccine.
Mm-hmm.
I'm not sure if you have information about the vaccine rollout plans in terms of priority groups, even monitoring for adverse reactions to the vaccine. Any information you can share?
I don't have any answers. What I can share with you is information that I know of. So I know at the hospital, we've already started to look at be able to purchasing the deep freezers to be able to handle storage of the vaccine. What you may have heard of is there's different vaccines. They need to be stored in different ways and managed or delivered in different ways. And so some of those pieces still need to be ironed out in terms of the best way to be able to get the vaccine delivered. I have heard through some of through my medical directors at the hospital that we have purchased our deep freezers. Some of the complications with the virus are being able to keep it under cold temperature. The vaccine itself comes, or the dosage of vaccine actually comes in a package of 500 vaccines for people. And so what we actually need to do is be able to figure out how to be able to deliver 500 vaccines at a time. Otherwise, we'll end up spoiling some of it if we're not able to get it all out or delivered. I've also heard that there are some issues with once the vaccine is delivered, it can't actually be moved around a lot, or we could start to potentially degrade the vaccine itself. And so there are some storage issues that we need to be able to do, and that will affect its ability to roll out. I know that long-term care is a priority group, both the residents within long-term care and the healthcare workers that are there. We're already trying to figure out what are some ways that we can efficiently deliver the vaccine when we're able to get it. I'm starting to hear that maybe in a couple weeks it'll be available, which is all great news. But I don't have any for sure's about who's getting it first, how it's going to be delivered. You know, sort of even who's going to get the first 200,000 doses and how they're going to figure who's going on, who's going to get that. What I know is there'll be probably multiple categories of priority groups, because you can imagine that long-term care residents would be a priority, but the caregivers that are also providing care for them, you also want to make sure they're protected. There's individuals in the rest of the healthcare sector that you want to protect. There's individuals out in the community that are the high-risk populations, like those over 80 that may not be in a long-term care home, that are at risk. And so we need to look at how to be able to deliver it across all those sectors. I think there's also more information to come about the vaccine, about whether certain vaccines may be better for certain populations, and trying to match the vaccine so that you get better uptake, or you get better efficacy within those individuals. What I've also heard is that it won't be just one dose of vaccine. What I'm hearing is that it'll be 2 doses over 3 weeks. Generally, what they're thinking is that there'll be some partial immunity that will develop after 2 weeks, but full immunity won't actually be present until about 4 weeks after the first dose, or a week after the second dose. And so there'll still be a little bit of time that we need to manage individuals who've been vaccinated with the potential risk of developing COVID, just like there is for influenza, where we have to wait for 2 weeks. I have also heard that the retirement home RHRA is advocating, and I do believe that retirement home residents are going to be seen as long-term care home residents. And so I don't think the splits, I don't think there's going to be a sort of a divide there. But other than that, that's as much as I can share. As I know information, Cathy, you know, you and I talk almost on a daily basis. So as new information comes, I'm happy to share that with you.
Great, thank you. One of the questions around the vaccine was around the communication and the rollout process. And in speaking with Erica and Noreen, the nurse leaders for the lodge and the terrace, at this point in time, in absence of any information or direction from anyone like public health, our feeling is we will be treating this just like the flu vaccinations. So we obviously get consent from the power of attorney substitute decision maker before administering the flu vaccination. So we envision that it would be the same process, of course. And then, of course, we'll be on heightened monitoring with the residents who have received the vaccination. But again, we're not sure at this point in time what we might expect in terms of side effects or symptoms as a result. So as that information comes to us, you will hear from me through the email blasts to keep you updated on that process for sure. Another question here is around cohorting, and I know you touched on it in your presentation. And perhaps this is something more for me to answer around cohorting here at Shepherd Village, and how we've gone about cohorting residents and staff. So, well, residents generally are in their own cohorts on the floors that they live in particular on second and third floor. They're even cohorted further because of those units being split and secured. And then, as Zahir has mentioned, when we do have positive cases, we try to cohort those positive cases together and move, and separate the negative residents who are negative from the residents who are positive. In relationship to staff, the principle that we use to guide us in staffing the units is cohorting. And I think we are doing a fairly good job, not perfect. It can happen where an employee has worked one particular unit and then perhaps a different unit. And some factors that come into play with that will be, so for example, when sixth floor had a number of staff ill with COVID, we had to replace those staff in order to provide the care to the residents. So, we have Paulette in long-term care, our scheduler, who is working full-time on that schedule to manage the staff and to ensure staff are cohorted as much as possible. You can imagine, because we're not doing admissions, we actually have a lot of vacancies. So it might be that if we do have a sick call, we may not have to, if we can't find someone who's already dedicated to that unit, we may not have to replace simply because we're down 10 beds on the unit. So ideally we want to replace it, of course, but not at the risk of bringing somebody else onto the unit that may have had exposure on another unit with a resident with COVID. So it's a decision-making process we take on a daily basis, every shift. What do we need to do to cohort the staff as best as possible? Any comments with that, Zahir? Zahir? Oh, I think maybe we lost Zahir, my partner. I'm on mute. Okay, sorry about that, Zahir. 1 second.
No. Okay. Can you hear me? Okay. Sorry.
Yes.
I think I muted myself, and then that sort of automatically
That's okay.
makes me muted by you. So yes, some of what we try to, cohorting isn't a common practice that we use in infection control right away. But during the pandemic, what we'll try and do is be able to cohort to be able to try and make sure that we prevent transmission spread. So often what that'll mean from a staff side is try to make sure that they get the same residents over and over and over again, or stay to the same floors. What we have noticed is that many of the times homes do end up in a bit of a pickle when there has been absences or COVID positive staff, and so sometimes it's been difficult. And don't always want to be able to lean on agency. And so sometimes that has meant moving around some of the home staff. We have tried from an infection control perspective, what we would end up doing is following up with the home to make sure that we're limiting the number of staff that would be going between the floors, or trying to make sure that the floors that the staff are going to are really only the same floor. So within the floors that they're traveling to are a bit of a cohort within that. From a resident perspective, what really, when it comes to COVID, the only thing we're sure of that we can cohort is actually positive residents together, because we know that both of them already have the organism. And so generally what we're trying as much as possible is making sure that those that we haven't identified with the organism or know that we've got a negative test for are remaining on their own or in the same areas that they are without any potential additional exposures. But it is a decision that we make sort of day by day, depending on what the results of new testing are. As you may be aware, during the outbreak, we are doing more frequent testing. And so as we're able to get negative results, we don't want to start moving people around, hoping that the negative results are meaning that we haven't had additional transmission. But we do multiple testings during an outbreak period, so that it's not just a test once and believe that they're negative. Hopefully that's helpful.
Yes, thank you. So Zahir, which is better, a disposable mask or a cloth mask, and how should they fit?
So let's talk about the fit first. The mask really needs to make sure that you've got it covering your mouth and your nose. As you will have seen in my presentation, the transmission of COVID-19 is actually droplet contact. And so it can be on the mucous membranes of your eyes, nose, and mouth. So by default, when you're out in the public, you do need to, because you are sort of doing the additional physical distancing, because your eyes aren't always covered when you're out and about with other people. Those of you that wear glasses have a little bit of additional protection on your eyes, but generally we're not wearing a kind of goggle type glasses. But you could, if you wanted to be out and about and be 2 meters and wanted to be within 2 meters of other people, make sure that you have all 3 mucous membranes covered. But for your mask, you want to make sure that it does cover the mouth and the nose comfortably, that if you happen to have to talk or move your mouth around, that it's not going to start sliding around, that you want to have good fit so that so that it's comfortable, it's not then going to become itchy. Many of the masks sometimes the masks will have a band of some type in the nose so that you can pinch it so that it can remain on top of the nose and doesn't start falling down. But really what you're trying to do is make sure that you've got adequate coverage of the mucous membranes of your nose and mouth. The thing about the the disposable mask versus the non-disposable mask is really whether you've got the ability to be able to reprocess the cloth mask. Both of them would be considered non-medical masks, so they shouldn't be used as a way of as personal protective equipment to prevent, like we would for a healthcare worker, to prevent transmission for COVID. But for you, if you were out in the public, if you were trying to figure out a disposable versus a cloth non-medical mask, the disposable just offers you the convenience of being able to throw it away and prevent the possibility of transmission. The cloth reusable mask means that you need to clean it. There's probably less expense with it, and you can reprocess it and use it many times, but you still have to do the laundry for it, and you can't really just kind of wear it and leave it on the counter all the time and think that you could just keep wearing it and wearing it and wearing it, because you're actually wearing it out in the public. If you're wearing it out in the public for the possibility that if someone was to come around, they wouldn't inoculate the mucous membranes of your nose and mouth, then you really want to make sure that it gets cleaned when it gets home, and you want to consider the outside of it to be contaminated.
Good. Which is more accurate, the regular COVID swab test or the fast, rapid COVID swab test? Which is more accurate, and which is being used at Shepherd Village?
Hands down, the current NP swab, which is very similar to the nasopharyngeal swab that we use for influenza, or the testing that you would go and do if you went to an assessment center. The testing that we would send to our labs. The rapid testing has lower what we call sensitivity and specificity. So really what that means is being able to rule out false positives versus true positives and false negatives versus true negatives. It's rapid, so it doesn't necessarily have as accurate or isn't as accurate as the nasopharyngeal swab that we do now. The nasopharyngeal swab is what we're doing in the lodge. The rapid test is really to try and make things a little bit more convenient for people. But there are issues with the rapid testing that I personally, myself, I'm not sure about how well it's going to, despite it's being in the news, how well it's actually going to be accessible to long-term care, because of the fact that there are issues with calibrating it and the number of times that you can do the testing. When we're trying to do a number of tests for, especially when we're trying to do weekly testing for our staff, we just don't have the time to be able to wait for that rapid testing for each of the staff. It's actually a lot easier to send 200 swabs to the lab and get them to do the traditional testing. It's got much better, what we call sensitivity and specificity. And so when we get a true positive, it's better at letting us know that it is a true positive versus a negative at telling us it's a true negative, versus the rapid test that's being released. Hopefully that helps.
And just to add to that, all the residents are tested with an NP swab. And the staff, there's a combination of types of swabs, not the rapid test, but there is something called a throat swab. So there's a different combination of what we're using with the staff. And sometimes it's based on what is sent to us from the ministry, because we have to order these swabs on a regular basis.
Sometimes that throat swab is a combination of throat and nares, like it's a double thing, isn't it?
It is, yes.
Yeah.
And then just as another touch point, we have put our hands up to be in a pilot project for the rapid tests. That would not negate the use of the swabs themselves, but I think it's an opportunity for us to have a bit of an early sign if someone may be positive, but of course we would be waiting for the result of the actual swab, the NP swab or the throat swab, whatever it may be, before we make a decision. So it's an opportunity to participate in research, which Shepherd Village really likes to do, and to be able to influence whatever changes need to be made in the system. So I will keep you posted on that. We literally just got the information today, and so you'll see some communication from me on that soon.
Cathy, could I add one thing about the non-medical masks that I forgot to add? There are some masks out there that you can see that have that exhalation valve on them. Don't buy those, because what they're doing is actually pushing extra air out, and you're just pushing more out to other people and contaminating. It may be something that looks like it's going to help you, but actually what it's doing is just pushing more air out. So the masks that don't have those valves in the front of them are actually better.
Okay, another question that was emailed into me was in regards to what staff and families can do to avoid or reduce a COVID outbreak. And I know your presentation would have covered a lot of that, but any final comments on that?
What I can say is there's no magic bullet and there's no rocket science. I was just involved in an analysis of a very large outbreak at another long-term care home to try and see what could we have put into place that could have prevented things. And it really is the traditional, unfortunately, the traditional infection control things that we've done that are there and available at the end of the slides, focusing on making sure that we are doing hand hygiene and equipment cleaning and the environment cleaning. But what we have really tried to focus on as the pandemic has grown is making sure that staff understand how to use personal protective equipment, especially because they're using it a lot now for all of the resident care, which is not what they're used to having done before, and just recognizing needing to support them to make sure that we can get those changed regularly, that they can throw them away, that we're not having to worry about self-contamination, and just providing them the supports to be able to make sure that they can keep themselves, because keep themselves safe, because they're really going to be the way, keeping the staff safe is going to be the way that we keep our residents safe, because that's going to be the introduction, making sure that the external people that are coming into the building are all sure that they're not having COVID. what we have recognized is that there's a lot of people who have rationalized away very minor symptoms, and after going to get tested have discovered that it's actually been positive. Quite frankly, I've heard frequently, I just have a little bit of back pain. I just have a little bit of back pain. And I too just have a little bit of back pain chronically, but it's trying to figure that out. And so many times I have already had experiences where people have said it's just a little bit of back pain, and they've gone to get tested and they've ended up having COVID. And so don't rationalize away little symptoms that you're just not used to. Go and get tested.
Okay, so we're a little over time, but we only have 2 or 3 questions left, if that's okay, Zahir. And there's 2 questions about masks. So can you help us understand the difference between a medical mask and a non-medical mask, as they appear to look identical?
So in fact, what you're probably purchasing out in the public is all going to be considered, or I would consider, non-medical. What we're like in healthcare, what we're accessing is considered a medical mask. So what we do is try and make sure that it has a particular bacterial filtration, viral filtration, water resistance, and so we've got what we call level 1, level 2, and level 3 masks. We've gone out to be able to make sure that we can source them all. The levels are really only to be able to differentiate the amount of splash that would be taken by the mask. From things like a surgeon wearing a mask that they would need in an orthopedic surgery where there'd be a very high volume of blood splash, down to just if you potentially got just a little cut on your finger, not very much blood, needing to wear a mask there, but all of them meeting a viral and bacterial filtration grade so that they would be considered health or medical masks. What you generally would be buying from commercial places or likely even some of the pharmacies and more now, even on Amazon or even the more regular places, I would consider them all to be non-medical masks. Those wouldn't be things that you would want to wear if you're a healthcare worker. Yeah, we make sure that the healthcare workers are outfitted with masks that are appropriate to keep them safe while they're in the facility.
And KN95 masks are available, but seem to not be promoted to the public. Would you know why?
So KN95s are really a Chinese designation for an N95. So the KN is actually a sort of Chinese terminology, and the N95 is the same way that we would use an N95 designation. They become more available, and there are some facilities that are looking at using them as a potential option. So it may be one of the reasons why they're not more regularly promoted within the public, because there are healthcare facilities that have looked at being able to acquire them to make sure that they have a suitable supply of masks. If healthcare facilities had them available or were using them, they're likely not considering them to be like an N95, but actually equivalent to a surgical mask. But because they've had a designation by an organization similar to the way that we would designate ours as an N95, we're looking at them as an alternative mask to be able to use. But my speculation is that it's probably not as available within the public because there's been quite a high demand for it within healthcare. The other piece to recognize is that, like many other products that are in high demand, things start to become counterfeit, and there starts to be a product that's out there that's on the market that's actually labeled as a KN95 or labeled as an N95 and actually isn't. And so I do know of experiences within healthcare where they have found out that what has actually been purchased has not been true stock or appropriately labeled stock, and have not engaged in that transfer, that purchase. My understanding is that doesn't affect the village or anywhere in the village at all.
Okay. One other question around testing, actually. So this person has said that when they have been tested at Scarborough Grace, they did the back of the throat and it was a throat burning sensation test, is how she described it. Now with new rules, people who don't have symptoms have to get tested at the pharmacy, and it seems to be a simple swoop with a Q-tip around the front part of the nasal cavity. Would this be considered, would this second test be considered a rapid test?
Yeah, that front nasal test is probably more similar to a rapid type test. It's not going to be as sensitive and specific as the nasopharyngeal swab. So recognizing that the nasopharyngeal swab is going much further in the nose to where what they actually call the crossroads in the passage. So it's actually sort of back where both of the nasal passages that meet. And so you're sort of, as some people have described it, is digging around for brain material. And so it's a much better specimen to try and identify the virus because it's actually within, it's further back. The nair swab is often what, as you has indicated, we would actually combine it with the throat swab to try and improve the sensitivity, the specificity, because as you can imagine, the organism is all kind of all back there in the same kind of place. So if you can't handle the deep nasal swab or the nasopharyngeal swab that we're trying to get, which is the better specimen, then often what we're trying to do is that common thing, the combination of the throat nair swab out in the public to try and make it a little bit easier and to be able to roll it out a little bit more quickly within the pharmacies is what they're trying to do, is say, really, if you're asymptomatic, a lot of people who want to be tested but don't know or afraid or just want to know for sure. And so it offers a little bit more rapid opportunity to be able to go get tested, a little bit lower sensitivity and specificity, but will likely still give you an answer that might make you feel a little bit better than not knowing anything at all.
The last two questions I believe are for me, actually. So one of the questions was around closing the lodge to essential caregivers with the increase in number of positive cases. As many of you would know, early in November, when we had a flare-up of cases on the 6th floor, we did ask essential caregivers to please not come into the home for 2 weeks while we were gathering results from the rest of the home in terms of the residents and staff. It gave us a chance to redeploy the screeners that are at the front are trained in working upstairs as well. So we redeployed those 4 staff that have been working at the front to help with the outbreak floor. So it became a bit of a resource challenge, but also just because we wanted to really have a better idea of what we were facing. And then after those 2 weeks, we opened the home again, albeit we still had COVID in the building. And then again, as you know, last week, early December, we have a second flare-up on the 7th floor. And so just when 6th floor was really calming down, we had this flare up on the 7th floor. So again, yes, we asked for 2 weeks while we redeployed those staff and worked with we're working with 7th floor. The home will be open again. I believe the date is somewhere around December 18th, December 19th. So essential caregivers, definitely, we want you guys to come back in. And so stay tuned for that in my communication as well. And then the last question was around testing of the essential caregivers, the families that are coming in. And I know I've had this question myself and Wendy at the town hall. We've had this question a few times, and I've provided some explanation at the family council meetings in the lodge in particular. I think people don't realize how many essential caregivers are coming into the home. We have over 80 essential caregivers coming into the home. Testing is a tremendous job. It takes 2 people for 2 full days just to test the staff. And then, of course, it takes 4 people, 1 full day to test the residents. And we're testing residents right now every 5 days. And now we're testing staff weekly. The resource demand on testing is tremendous. And so unfortunately, adding 70, 80, 90 more people to that is not something we can manage at this time. I do appreciate the challenge with getting tested, but it is not something we can add to our plate right now with testing, given all the testing we're doing now, and the resource demand that it takes. And by the way, it's not just testing. After the test, it takes another couple of people to receive all those test results, which with staff, we're looking at over 300 staff. And then of course, in the lodge and in the terrace, we're looking at around 250, almost 300 residents. So we are testing people every week at the rate of almost 700 people. So, and then getting all those results, logging all those results is another big job for us. So on that note, I don't see any other questions in the chat. However, you know, Wendy does do the town halls now once a month, so please feel free to send in your questions. We are doing our best to provide as much information to you as possible. And then you all know where to find me. I'm always here, and you know how to get in touch with the nursing departments in the lodge and the terrace. Any staff that have participated in this town hall tonight, thank you. We hope it was informative for you as well as the families of the lodge and the terrace. Finally, in closing, Zahir, thank you. For all the families, you need to know that Scarborough Health Network has done an amazing job supporting Shepherd Lodge. They are here every week providing, and there's Zahir, providing us with lots of support and education and training, letting us know where we need to improve, letting us know where we're doing well. And Zahir, we really appreciate all your support that you've given us. Thank you. Okay, so good night, everyone. Thanks again, and please take care of yourselves.